Deviated septum. The wall dividing your nostrils is almost certainly not straight. Studies suggest around 80% of people have some degree of septal deviation. That number isn't a typo. Most people walking around with slightly crooked internal nose walls have no idea. Your nasal septum is the cartilage and bones separating your two nasal passages. In a perfectly symmetrical septum, airflow through both sides is equal. In reality, most septums shift to one side, narrowing one passage and widening the other. Mild deviations cause nothing noticeable. Moderate ones cause chronic congestion on one side, louder breathing, and snoring. Severe deviations obstruct airflow significantly and contribute to sleep apnea. Most people with deviated septums attribute their symptoms to allergies, sinus issues, or just how they breathe. They take antihistamines for years without addressing the actual structural issue. Correction requires surgery. Septoplasty straightens the cartilage through the nostrils with no external incisions. Most patients report dramatic breathing improvement. Most people who need it never pursue diagnosis because the symptoms normalize. Mild scoliosis. Look at someone from behind and check if their shoulders are level. Check if their hips sit at the same height. Slight asymmetry might be poor posture. It might be a structural curvature of the spine. Scoliosis is a lateral curvature of the spine. Severe cases are obvious and require intervention, but mild scoliosis, curves of 10 to 25 degrees, often goes unnoticed for years or a lifetime. The spine has developed a slight S or C shape instead of running straight. Most mild scoliosis in adults causes no significant pain on its own, but it does create compensation patterns. One shoulder sits higher, one hip protrudes further. The body distributes weight unevenly. Over decades, this contributes to back pain, muscle fatigue, and hip problems that get attributed to everything except the underlying curve. Many adults with mild scoliosis were never screened as children or had it dismissed as insignificant. They're told to work on posture when the issue is structural. Flat feet. Roughly 30% of people have flat feet, meaning the arch on the inside of the foot has partially or fully collapsed. Most don't know it's affecting anything beyond how their shoes wear. Arches function as shock absorbers. They distribute the force of each step through the foot structure efficiently. When the arch collapses, that distribution changes. The ankle rolls inward, called overpronation. The knees track slightly inward as compensation. The hips and lower back adjust to accommodate the altered mechanics. People with flat feet commonly experience knee pain, shin splints, plantar fasciitis, and lower back pain. They visit doctors for each complaint separately and treat symptoms without identifying the root cause. The connection is often missed because flat feet themselves aren't painful. The foot looks fine. The pain appears elsewhere and seems unrelated. Arch supports and specific footwear significantly reduce downstream pain. Most people with flat feet spend years managing knee and back issues without addressing what's happening at ground level. Morton's toe. Hold your foot out and look at your toes. If your second toe extends past your big toe, you have Morton's toe. It affects somewhere between 10 and 30% of people and influences every step you take. In a typical foot, the big toe bears the most weight during gait. It's the last point of contact before your foot leaves the ground. When the second toe is longer, weight distribution during walking shifts. The big toe loses its leverage advantage. The forefoot takes on more pressure than it should. This leads to calluses forming under the second metatarsal head, increased risk of bunions, and altered gait mechanics that travel up the kinetic chain. Hip rotation changes subtly. Lower back compensation follows. Morton's toe is also associated with Morton's neuroma, a painful thickening of nerve tissue between toes, and metatarsalgia, chronic forefoot pain. Most people who have it never make the connection between toe length and these downstream issues. Forward head posture. Your head weighs roughly 10 to 12 pounds. When it sits directly over your spine, that weight is distributed efficiently. For every inch it moves forward from that neutral position, the effective load on your neck approximately doubles. By the time your head is 3 inches forward, your neck is managing the equivalent of 40 pounds. Forward head posture means your skull is positioned in front of your shoulders rather than stacked above them. Phones, computers, and desk work train this position over years. What starts as a muscular habit becomes a structural change. The cervical vertebrae remodel. The muscles at the back of the neck become chronically shortened. The symptoms include neck pain, shoulder tension, headaches starting at the base of the skull, and jaw problems from the altered relationship between head and neck. People treat each symptom separately: physical therapy, headache medication, jaw guards. The underlying problem is structural positioning that develops so gradually it stopped feeling wrong. Clinodactyly. Look at your pinky finger. Does it bend slightly inward toward your ring finger? That curvature has a name. Clinodactyly is the bending or curving of a finger in the plane of the palm, most commonly affecting the little finger. Around 10% of people have some degree of clinodactyly. In most cases, it's entirely cosmetic and causes no functional limitation. The finger simply points at a slight angle. The condition is usually genetic and often runs in families without anyone ever naming it. It can appear as an isolated variation or alongside other conditions. Mild cases are so common they're frequently not considered abnormal. People with clinodactyly typically notice their finger looks different when they pay attention, then go their entire lives without it mattering. In more severe cases, finger function can be affected, and surgical correction exists. But most people reading this who have it have never given it a second thought. Tongue tie. Underneath your tongue is a band of tissue connecting it to the floor of your mouth. This is the lingual frenulum. In some people, this band is shorter, thicker, or positioned further forward than typical, restricting tongue movement. That's ankyloglossia, commonly called tongue tie. Tongue tie is most discussed in infants because it affects breastfeeding, but mild to moderate cases in adults go largely undiagnosed. The tongue compensates through alternative movement patterns. The jaw, neck, and throat muscles recruit differently. In adults, tongue tie contributes to speech patterns that sound like difficulty with certain letters, accelerated tooth decay from reduced saliva distribution, tension in the jaw and neck, and sleep-disordered breathing because tongue positioning affects airway dynamics during sleep. Most adults who have it developed compensations in childhood and never had a name for the structural issue. Diagnosis requires a practitioner who knows to look for it. Pectus Excavatum. Press the center of your chest. In most people, the sternum sits roughly level with the ribs. In about 1 in 300 people, there's a depression. The sternum sinks inward, creating a hollow in the center of the chest. This is Pectus Excavatum, sometimes called funnel chest. Mild cases are hidden under clothing and go largely unnoticed. The person is aware of a slight indentation but doesn't think much about it. In moderate to severe cases, the depression displaces the heart slightly to the left and limits lung expansion. People experience reduced exercise tolerance, shortness of breath during exertion, and heart palpitations. These symptoms often get attributed to fitness level or anxiety for years. The psychological impact of mild to moderate cases is often underestimated. Many people with Pectus Excavatum avoid situations requiring them to remove their shirt well into adulthood without having a name for why the center of their chest looks different. Winged scapula. Ask someone to push against a wall with their arms extended and look at their shoulder blades from behind. In most people, the blades lie flat. In some, one blade lifts away from the rib cage, creating a wing-like protrusion. Wing scapula occurs when the muscles stabilizing the shoulder blade to the rib cage weaken, or when the nerve supplying those muscles is damaged. The long thoracic nerve, which controls the serratus anterior muscle, is particularly susceptible to compression injuries. People with mild wing scapula often don't notice until someone points it out. They might experience limited shoulder mobility, a vague aching around the shoulder blade, or weakness during overhead movements. The condition gets dismissed as bad posture for years. Physical therapists and gym trainers tell people to work on their shoulder stability without identifying the specific structural issue. Targeted rehabilitation for serratus anterior weakness specifically addresses it. Unequal leg length. Stand barefoot and have someone observe your hips from behind. In most people, they're level. In a significant portion, one hip sits higher. One leg is anatomically shorter than the other. Leg length discrepancies of up to 2 centimeters are extremely common. The asymmetry means every step involves a slight hip drop on the shorter side. Over a lifetime of walking, this translates to compensatory curvature in the lumbar spine, hip misalignment, and the entire musculoskeletal chain adapting to the imbalance. People with unequal leg length experience chronic low back pain, hip pain, and knee problems on the shorter leg side. Shoe wear differs between feet in ways they attribute to gait habits rather than structural cause. Simple diagnosis involves measuring leg length during a medical examination, which isn't routinely done. A small heel lift in the shoe of the shorter leg significantly reduces compensation patterns. Many people manage years of back pain without this straightforward intervention. Bifid Uvula. Open your mouth and look at the small piece of tissue hanging at the back of your throat. That's the uvula. In most people, it's a single rounded piece. In about 1 to 2% of people, it's forked, split down the middle, 2 lobes instead of 1. This is a bifid uvula. It's considered a microform of cleft palate, meaning the tissue that forms the palate didn't fully fuse in the midline during fetal development. A bifid uvula can appear alone or alongside a submucous cleft palate, a split in the palate muscle hidden beneath intact mucosa. Most people with a bifid uvula have no symptoms and never notice it. Some have associated speech or swallowing characteristics. It's diagnosed when someone happens to look far enough back in the throat. The reason most adults don't know whether they have it is simple. Nobody checks their own uvula regularly. Preauricular pit. Look in the mirror and examine the area just in front of your ear where it attaches to the side of your head. Some people have a tiny pinhole there. A small indent barely a millimeter across. This is a preauricular pit, a congenital remnant from ear development. Specifically, during fetal development, the ear forms from 6 small tissue mounds called hillocks that fuse together. Incomplete fusion leaves a small sinus tract, a narrow tube extending beneath the skin. Around 1 in 100 people have it. Most are unaware because it causes nothing. The pit is painless and barely visible unless you're looking for it. Occasionally, these pits become infected, particularly if debris collects in the tract. Most people who experience a swelling near their ear canal and don't know about the pit have no idea why it's happening. It's considered an evolutionary vestige, essentially a remnant from when our ancestors had structures more resembling supernumerary nipple. Your body developed along a milk line during fetal development. This line runs from the armpit down through the chest and abdomen toward the groin, following the same path where nursing animals have multiple nipples. In humans, all tissue along this line except the 2 primary nipples typically regresses before birth. Sometimes it doesn't fully regress. Somewhere between 1 in 18 and 1 in 100 people have an additional nipple somewhere along this line. The number varies significantly between studies. Supernumerary nipples are almost always mistaken for moles. They're typically small and may lack an obvious areola. Most are on the torso below the primary nipples, but they can appear anywhere along the milk line. They're medically insignificant in almost all cases. They have no function. They cause no problems, but most people who have them have been told by doctors it's just a mole, because most doctors don't bother looking closely. Accessory Navicular. The navicular is a bone in your foot near the arch. In a small percentage of people, a secondary piece of bone develops alongside it. This accessory navicular sits in the soft tissue of the arch, sometimes fused to the main bone and sometimes floating separately. About 4 to 14% of people have an accessory navicular. Most never know it exists. But in others, the extra bone causes a prominent bony bump on the inner arch and chronic pain during activity. The pain pattern mimics plantar fasciitis almost exactly, arch pain that increases with activity and improves with rest. Most people with symptomatic accessory navicular spend months or years treating plantar fasciitis without improvement because that's not what they have. Diagnosis requires an X-ray that specifically includes the midfoot. Standard foot X-rays are often angled in a way that misses it. A proper diagnosis changes the treatment approach entirely. Diastasis Recti. Your abdominal muscles run in 2 parallel bands down the center of your torso, separated by a band of connective tissue called the linea alba. In most people, this gap is narrow. In diastasis recti, the gap widens and the linea alba becomes thin and stretched. The result is a ridge or dome shape visible down the center of the abdomen when you do a crunch. Belly button to lower sternum, the core bulges outward rather than pulling in. It's most associated with pregnancy because the growing uterus creates prolonged outward pressure on the abdominal wall. But it also occurs in men, particularly those who spent years doing heavy-loaded exercises with poor bracing technique or who carry significant abdominal weight. People with diastasis recti often experience low back pain and pelvic floor dysfunction because the core no longer stabilizes the spine efficiently. Many assume they simply have stubborn belly fat or weak abs and train harder, which in some cases worsens the gap rather than closes it. Specific corrective exercises exist for diastasis recti. Standard crunches and sit-ups are typically contraindicated,